Hi everyone, my name is Matthew Dartt. I'm the Assistant Director here at UCLA Santa Monica, and today I'm going to present to you on our UBreathe program here at UCLA and leveraging RT navigation and telemedicine. Joesph Van Vleet's going to take over here in a little bit, and he's going to talk about what he's done in the initial couple years of our launch of our program and how he did that with our patients and coordinated with various disciplines across the health system. So the goal of this program when we launched it was, like many in the country, was it was designed to utilize a respiratory therapist as a patient navigator for these patients with acute or chronic lung conditions. And something I asked Joe to do initially when we launched this program was not only see COPD patients, as some institutions are doing, but actually see anybody that was admitted with the acute exacerbation and see if they could utilize these services. And just in general, improving overall patient education, assisting with respiratory-related equipment issues, coordinating with DMEs, hopefully presenting readmissions by partnering with care coordination. And something we've done that I think is unique to the program is we've partnered with local SNFs and our physicians that are within the health system that go there. And that's really provided a familiar face to our patients and helped them navigate the health system pre and post-discharge. And he's done a fantastic job at that. Initial support from this program came from our adult pulmonary and critical care team and pediatric and pulmonary. And out of those specifically, our cystic fibrosis team directors, Dr. Shagan, Dr. Lee, Dr. Okilo, Dr. Wu were really early utilizers of the telemedicine side of that and love that. And I think they really helped drive the program forward, which has been fantastic. And Dr. Schwab and Kadir, who you just heard from, they reached out to us when they heard our utilization of telemedicine and utilizing an RT navigator, and they were interested on how we did that. And after they reached out to us, we helped them launch that post-ICU clinic in conjunction with pulmonary and critical care, rehab, pharmacy, and care coordination. And it's really been successful utilizing an RT navigator in that aspect as well. And I think that's really unique to the program is really having a respiratory therapist coordinate all that care, which in the past may have gone to nursing or even a physician. So far throughout this program, we have a 8.5% all-cause readmission rate for the patients that have been enrolled in the UBreathe program, which is fantastic. I think when we look at the next quarterly data, it's going to be even closer to 6.9%. And this is for patients with an acute or chronic respiratory condition. And out of those, even only 4.8% were actually readmitted with pulmonary issues, which tells me that our navigator is doing his job. Implementation of discharge follow-up via phone calls, video visits, or in-person SNF visits were achieved with 83% of these patients enrolled in the program. And we had some initial hurdles with that when we first launched the program. Joe's done a really great job, and he'll talk a little bit more about how he was able to get that more up to the 90% range and making sure that he had that contact post-discharge. Since the initiation of the post-ICU clinic, as I think Dr. Schwab went over already, is we've had 0% readmission rate for the post-ICU recovery clinic, which has been fantastic. And a lot of that is due to this program and the whole team's involvement with it. So our pulmonary navigator, Joe Van Vleet, he's been incredible since the launch of this program. I couldn't ask for a better pulmonary navigator. He's working nights, weekends, performing countless video visits, even, as I said, going to the SNFs to make sure our patients felt supported and their health needs were met, whether that was respiratory or he could reach out to care coordination and make sure all their health needs were met. Since its launch now, we've seen over 150 patients, probably closer to 200 now, and enrolled over 90 patients in the program with over 150 follow-up video visits. Then that's telemedicine alone, face-to-face video visits. So just because they're seen within the program doesn't necessarily they're going to be enrolled into the UBreathe program. So if maybe they just need some education with respiratory equipment, instruction on inhalers, or they just do one video visit with our pulmonary navigator and they feel like that sufficed. Prior to COVID, we were working with the navigator and pulmonary and critical care and family medicine to work with the local communities and actually hoping to do a UBreathe lung health fair and provide asthma, COPD screenings, OSA screening, and lung cancer screening, and the necessary resources for these patients or these communities. And we hope to do something with that more virtual now, especially with online learning, maybe providing asthma screening in schools with some of the Zoom learning that's going on, and being able to refer to local clinics and specialists for them in their communities. We'd like to partner with them to provide definitely smoking and vaping education nowadays, especially with all the Zoom classes. As I said, I think this is a fantastic opportunity to do something innovative and use this program to grow into that field. Hopefully this year upcoming, we're going to increase sleep referrals by partnering with our sleep docs in Pulmonary and use some of the OSA screening tools we have available and protocols to have the appropriate referrals prior to discharge to further decrease that readmission rate for patients that we may be missing now. Obviously, we'd love to have more navigators. The more the merrier. I think we've proved our worth, and we'd like to continue this and hopefully get a few more grants and maybe a bronchiectasis clinic that's very navigator driven, similar to what we have done with the post-ICU clinic. Hopefully, utilizing navigators too in the UBreathe program, we'd like to see initiation of online pulmonary rehab, or at least resources that patients could use that we can provide through the program utilizing the navigator position. Administrative support is key. So anybody that has developed a program knows how hard it is to prove the worth. And if it's a new concept to the health system for anyone, it's hard to approach the return on investment. I think there's a few resources out there, and partnering people with Crystal Craddock at UC Davis has been fantastic for us. We model a lot of our program after the road program up there, and utilizing the tools they have has been key to our success. So having an administrative champion or two in your corner is needed for any successful program. I'll just say that out front. We weren't able to actually produce an ROI or return on investment with our COPD readmissions alone. We already had a number of initiatives targeting that population, and I think our fines were only around the $50,000, which is not insignificant, but won't cover a whole salary of a navigator. So some of the reason why we wanted to have a general pulmonary navigator is that was what we were saying our ROI would be, or our downstream revenue is we would cover COPD, CF, bronchiectasis, pneumonia, etc., versus a COPD navigator alone. So when you go to administration, clearly stating the goals and objective of your programs is extremely important. And knowing where your possible revenue, cost avoidance, and actually the downstream revenue is what our finance managers want to hear, and how they can be able to support the program and additional staff in the future. These are things they want to hear. So we really made friends with our finance and budget manager, and when looking at care coordination role within, we really made friends with our finance and budget manager when developing the ROI, and they were able to help us do a deep dive and really talk about the downstream revenue when we went to administration and asked for the full-time employee to fill this spot. And again, when we're partnering with Pulmonary and Critical Care, has been amazing. And our navigator actually rounds with them daily when he can, and he's almost become like their PA. And this has been amazing for the growth and development of the program and our navigators' knowledge in general. So those are the key lessons we turned in developing the program. Everybody wants to see an ROI, and I got to be honest, sometimes it's just not there. So talking about what's right for the patients and possible downstream revenue and being creative with it was important in the development of our program. And I know it will be when we ask for more positions moving forward. And data collection on showing that your program is successful is key, and having that organized for your navigator so it's easy for them to input prior to the launch of the program is key. And knowing what you want to do with your telemedicine program, how you're going to have the patients utilize that, and Joe's going to get into that in just a second, and making sure that they have somebody to help them utilize any devices or programs you have within your facility is key. So with that being said, I'm going to turn it over to Joesph Van Vleet, our pulmonary navigator, and he's going to run through what he's done with our program in the last year and a half, 2 years. Thank you.
Thank you, Matthew. Hello, everyone. My name is Joe Van Vleet, and I am a respiratory therapist and the pulmonary navigator here at UCLA. So let's talk about leveraging RT navigation and telemedicine. By the end of this presentation, the viewer will learn about the development and implementation strategies to improve patient outcomes by utilizing an RT navigator to enhance patient engagement, education, and self-care via implementation. The viewer will be able to describe the process, which is reduced hospital readmissions associated with chronic lung disease, by performing follow-up video visits to assess learning outcomes and reinforce education topics relevant to patient's disease. The viewer will be able to implement new strategies to manage and integrate a telehealth program with discharge navigation. And finally, the viewer will be able to effectively use the Navigator program for recruitment and follow-up in the post-ICU discharge process. So where does one start? After pitching the Navigator program to the big-ticket multidisciplinary groups, the rest seem to fall into place. The biggest compliment I hear is, how did we ever get by without you? Once things got going, everything I was doing just sort of made sense, and I made connections as time went on. Pulmonary and critical care medicine is obviously the best place to start. We also presented the program to care coordination, which consists of case management and social work, nursing administration and clinical nurse specialists, ambulatory care, east-west medicine, and the geriatric medicine, among others. So pulmonary and critical care medicine. This partnership is perhaps the most important for obvious reasons. Notably, being invited to round with the pulmonary consult team enhanced the Navigator program in a few important ways. I was lucky to have already known and worked with a few of our pulmonary docs, but this was the best way to jumpstart the Navigator program. After I started rounding with the consult team, the Navigator workflow expanded pretty organically as new ways I could assist to improve patients' outcomes kept arising. Capturing all patient types, whether inpatient or outpatient, was the first enhancement. This basically allowed for our program to cast a very wide net. Eventually, the physicians would send me outpatient referrals. I would meet patients during their clinic appointments. These are generally your frequent flyers, the high healthcare utilizers who needed an extra set of eyes on them to assist with home disease management. These patients could contact me for advice during a flare, saving them their usual trip to the ER for steroids and nebs. I could relay the patient's symptoms to the physician, and they would write a script or we would just up their daily respiratory regimen to manage the flare and keep them home. This really works. Continuing on, I could assist the consult team with optimizing patients' respiratory therapy in the hospital and help prepare their home regimen after discharge, assist with lining up specialized DME, home inhaler and ACT regimen optimization, etc. This partnership led to collaborating on the post-ICU recovery center. Continuing education for the Navigator. Obviously, patient education is the goal here, but there has been no better way to elevate my level of knowledge than by hanging out with the pulmonary docs. At first, I felt like my brain was melting, but pattern recognition eventually kicked in and things began to stick. These physicians really go the extra mile to make their Navigator better at understanding the full scope of chronic lung disease treatment, reading CTs, you name it. Geriatrics. So this partnership kind of happened as a result of following a patient to the local SNF. Like, I literally followed the patient across the street to the local SNF. So many of our elderly chronic lung patients will spend a few weeks at the local SNFs after discharging before going home. This ended up being such a blessing, especially with a few patients I knew were going to be difficult to follow up with. Can always get a vibe from certain patients that they are just going to disappear off the face of the earth after discharge, and I'm never going to be able to follow up with them. After getting permission from my bosses, I was allowed to visit patients at the SNFs and have even more time to educate and prepare for their eventual discharge home. So now these patients had nowhere to hide from me. After connecting with the geriatrics team, we could work together to fine-tune their respiratory regimen at the SNF. For example, switching their nebulized medications to inhalers as they were closer to discharge, just like we do in the hospital. So some EMR tools. The patients on the pulmonary critical care consult list tend to be the more complicated pulmonary cases. But what about those patients with straightforward exacerbations? We created a few reports that pull the current list of chronic lung patients being hospitalized from our charting system, even those hospitalized for issues not related to the chronic lung disease. These are always good opportunities to assess the patient's home RT regimen, health literacy level, and just make sure they're on the right track. Let's talk about leveraging telemedicine. So following up after discharge with a video visit is by far the best way to assess in-house education outcomes. But how do we get the patient to buy in? Getting patients to follow up with their primary care physician is hard enough, let alone with me. So engaging the patient or a close family member is an absolute must. I generally have more time to spend with the patient than any other person in the UCLA health system, especially when I was just starting out. In fact, back then I may have spent too much time with the patients. So much time they were probably sick of me and wanted nothing to do with me after they left the hospital. But seriously, Patients are used to healthcare workers cycling through at such a high rate, it's hard to remember who anyone is. So the first and most important step is to introduce myself, take a seat at bedside, and listen for as long as it takes. Patients become engaged when you sit for an hour listening to their concerns and getting to know them personally, not just their medical history. So the health confidence scale, if you could use one tool to assess a patient's confidence in managing their health, navigating healthcare resources, and above all, the patient's health literacy level, this one is so simple yet so informative. For example, if you asked a patient who had 5 hospital admissions this year for chronic lung exacerbations how confident they are in managing their health, and they answer with a 10 out of 10, you know you have some serious work to do. Or on the other hand, the patient may answer 6 out of 10. So that begs the follow-up question: what would it take to improve your score? This is a question I ask when I first meet the patient and at the time of discharge and after a follow-up video visit. After getting a sense of their health literacy level, the patients are given pretty intense education during their admission with PowerPoints and demonstrations on chronic diseases 101, respiratory medications, delivery devices, inhaler technique, breathing techniques, cleaning devices and equipment, action plans, and self-monitoring. The goal is basically to make the patient the expert on their disease. It's a lot of information, especially when you're sick in the hospital. So after providing this education, we realized just how important the follow-up video visit is to assess our learning outcomes. So now that a connection has been made, the patient is engaged, how can I make sure they're able to follow up? Short of purchasing a new iPad for the patient, and I've thought about it, getting the right app downloaded to their phone, helping them sign up for an account, and running a test video visit is the only way, unless you don't mind spending the first 45 minutes of their video visit troubleshooting. Also, very important to put their video visit on the calendar before they leave, preferably the morning of the next day. What makes the video visit so valuable? Well, being able to eyeball the patient in their home environment with their own equipment is invaluable. I always have the patient walk me through their home respiratory routine step by step. This is where small mistakes can be caught and corrected. This is an opportunity to use the teach-back method and have them teach you to see how much knowledge the patient retained from their admission education. And understandably, the patient will most likely need some reinforcement. I mean, let's be honest, when I have a cold, I don't want to be educated on anything, let alone having pneumonia and in the hospital and not getting sleep. Sometimes the patient might need a few extra video visits to review the education materials and reinforce particular items. So here are just a few of the errors that were caught during video visits. Compiling all 4 of their nebulized medications into one cocktail treatment. After catching this, I was like, how long does this nebulizer take? Like 45 minutes? 5 minutes, the patient reports. And the patient's wife says she's always wondering why there's so much foam and liquid in the nebulizer after the treatments. The DMV vendor RT happily switched a patient's AVAPS interface from a full face mask to nasal pillows. This was a patient whose prior admission was for hypercapnic respiratory failure due to under support from her BiPAP and nasal mask. Her mode was changed to AVAPS, the interface was changed to a full face mask, and her gases were markedly improved. Unfortunately, the vendor RT took the full face mask with them after switching her to nasal pillows, and before I could get the RT to return to the patient's home and switch them back, the patient was back in the ER with, guess what? Hypercapnic respiratory failure. The patient's home nebulizer was not nebulizing. I could see this, I could see it in front of my eyes. There was no visible aerosol. You could hear the compressor, it was loud, nothing was happening. I mean, how long had this been going on? Who knows? Even when patients discharge to a SNF, transitional errors can happen. The day after discharge, this patient reported, they canceled one of my inhalers. This was not a patient error, but a prescription somehow didn't make it to the SNF. Luckily, this was caught the day after discharge because this was the patient's once daily triple therapy inhaler, her most important inhaler. Having a partnership with the geriatrics physician made this an easy fix. So, charting. Someone once told me if you didn't chart it, it never happened. Our information services and solutions team has been awesome with adding the navigator charting into our respiratory therapy flowcharts, adding the navigator education completed tab for our boost which is better outcomes by optimizing safe transitions pilot. And this lets the primary team know that all the navigator education and discharge planning has been completed. We also created some smart phrases to use during encounters such as bedside education sessions, follow-up video visits, pre-clinic screening, you name it. So the Post-ICU Recovery Center. You may have seen the presentation earlier by Drs. Kadir and Schwab. Well, the navigator workflow perfectly aligned with the clinic's needs. Honestly, the timing of these two programs coming together couldn't have been better. The navigator position was brand new and the clinic was in its early phases of creation. It was just meant to be. So I found out pretty quickly that clinic candidates and their family were almost a sure thing once the clinic was introduced. They didn't need the same kind of convincing that patients needed to get them to follow up with me. After hearing that not only would they be seeing a multidisciplinary team consisting of the same RTs, PT, OT, and social worker that cared for them in the ICU, they would also be following up with the ICU pulmonary and critical care physicians who saved their lives. They wanted to know where to sign. And these are very sick patients, so many required ECMO and tracheostomy to get through it. Many will spend some time at LTACs and acute rehab centers before they're even ready to be seen in our clinic. So meeting and connecting with the family is just as important as meeting the patients. And for many of the patients, a spouse or loved one ends up being their point of contact throughout the recovery process. So data collection. So collecting data allows us to present hard numbers as well as patient satisfaction metrics to upper administration to prove the value of the Navigator program. A few of the data collected are health confidence score on initial meeting, at discharge, and after follow-up video visit, current length of stay versus previous length of stay, ED admissions, admissions for our frequent flyers, obviously, and readmissions within 30 days of discharge, patient satisfaction surveys using our survey questionnaire, and smoking cessation program referrals. So here's our data collection for the fiscal year 2020, which was updated with our last quarter. Our all-cause readmission rate is 7.2%, with only 5.1% pulmonary related. We had no negative patient satisfaction surveys. We were able to get 83% of our patients to follow up after discharge. And since its launch, we have now seen over 150 patients and enrolled over 118 patients in the program with over 150 follow-up video visits. And since the initiation of the Post-ICU Recovery Center, we have had a 0% readmission rate to date, which is awesome. Well, thank you so much for watching my presentation. I have learned so much in the last year or so, but I know I have so much to learn. The best part about this role is that I continue to learn and grow as the program grows. I just have to give credit to Matthew Dartt for his years of work that he put into developing the Navigator program at UCLA. Without him, none of this would be possible.